Superintendent of Eatonville School District, and we are so happy to have our families and community join us this evening. Today is the end of the first day back for middle school students, and many of those students, it's been almost a year since they walked into our buildings. And next week, we will join and enjoy having our high school students back. Today also is the first day of official sports in 2021. So we are so pleased that you are joining us this evening. This evening is an evening about science and safety. Just logistically, there have been pre-submitted questions that were submitted over time. And so we have our medical experts that will be walking through that. If time is permitted, time permitting, we will be able to get to the questions in the chat. And also just a word, this evening really is about science. We have with us our experts, our friends who have come from Lewis County working with us to really be as safe as possible. And we feel very strongly that our mitigation strategies are appropriate and aligned to the CDC. And this evening you will be able to meet the infection prevention and antimicrobial consultants. We call them the IPAC group. This is a local group that has helped schools reopen. IPAC is headed by Angela Dixon, who is an infectious prevention regional director for Providence Health and Services. She's not here with us this evening. However, we have our other wonderful members as well. Laura Ebinger, who is board certified in infection prevention and epidemiology, and Dr. Preeti Kondal, the medical director of infection prevention for Providence St. Joseph Health Southwest Service Area. And between the three of them, they have at least 60 years combined in the business, so to speak. And so their walkthroughs, they have been site visits, they have worked hand in hand with the other two officials that you will be able to hear this evening. We have Heidi is our school nurse, and you can see her, as well as John Fisher, who is our maintenance manager of maintenance and operations. So this is an evening for questions and information, and we hope that you enjoy it. And with that, I would love to turn it over to Dr. Kondal. Welcome.
Thank you so much, Kristen. That was a very generous introduction. Thank you for having us come and talk to you a little bit about what COVID-19 is and some of the mitigation strategies that have shown to benefit not just schools, but communities, hospitals, and everywhere that we can bring that into the school so that the kids are safe and can do in-person learning. Because over the past year, we know it's impacted a lot in regards to their mental health and just their overall wellness, that I think it'd be good to get some information and get them back in school. So what I'm going to do is I'm going to share my screen and we'll get started. All right. So what is just what I'm going to provide is just basic information as to what you need to know about COVID-19, some of the basic steps to help to make sure that the kids are safe, that the staff is and teachers are safe, and kind of reassure you that a lot of these things are already being done and there's science that supports that. Um, the kind of the learning objectives are providing basic information about COVID-19, actions to protect personal safety at work, health and safety, discuss actions for safe interactions with students and just coworkers for the staff, and then also minimize transmission from COVID from the environment. I think to start off with, it's always humbling to see where we're at. We've had over 100 million confirmed cases of COVID-19 and over 2 million deaths, which is the most that a recent pandemic has had. So that's quite a bit. And in the US itself, we have over 26.2 million in confirmed cases and over 440 deaths. Washington, we're looking at over 300,000 and over 4,000 deaths. In Pierce County, is about almost 34,000 with almost 500 deaths. And looking to see how we compare to some of the other nations worldwide. And unfortunately, we're leading this pack. This is not the pack that we would want to lead on, but the number of cases since this has been discovered has been the highest in United States. And you can see where the countries do follow. And looking at, Pierce County, we're following the same trend that has been followed for the entire United States in Pierce County, where, early on the cases were low, but over the past 3 to 4 months, the cases have increased significantly and exponentially. And this is just looking at the number of cases. And I did not include the graph with the number of deaths, but it is almost identical to this, where the number of cases of deaths are increasing the same way. And that goes hand in hand with the increased number of cases, you're going to have increased number of deaths. So some of the basics for COVID-19, coronavirus is a virus that has been known for a long time, and we've known about there's about 6 types that we have known about. But in the end of 2019, we had a novel coronavirus that was identified in Wuhan, China. The 4 of the types that we have known about, they cause the common cold, mild respiratory symptoms, the sniffles, and a little bit of a cough, and then you get better. And then there have been 2 types of these coronaviruses that can cause more severe infections because they bind more to the lower respiratory tract. So not only do they cause the upper respiratory or upper tract, but they also affect the lower tract. So the initial SARS-CoV-1 was the SARS outbreak in 2003. And then now the SARS-CoV-2, which is very close in lineage to that one. And that's why they call it the SARS-CoV-2, but it causes the disease COVID-19 or COVID, and then they call the 19 for the year that it was discovered. The other more severe is MERS, which stands for the Middle Eastern Respiratory Syndrome, which we started to know about in the 2010-2011 timeframe. And still there are cases that are known for MERS, but they're mostly in the Middle East or if there's travel that is happening. The reason that these 2 types, the SARS and the MERS, are unique is that they are highly contagious compared to the common cold, and they also cause more severe disease again because they do affect the lower respiratory tract. What we do know is looking at the median reproductive number. What that means is if someone is infected, how many more people can be infected with this, that from that infected person is about 2.4, and this is more the United States data. I think there's been a lot of questions as to what's going to happen with the variants that are present. So that median reproductive number is not known yet because we're still discovering where all the variants are and how it is spreading. But for the wild type, as we call it, for this virus, it was about 2.4. Comparatively to influenza early on, I think there was a lot of comparison that this is just a bad flu. Flu is usually about zero point 0.9 to 2.1. And then measles, which is thought to be one of the most infectious viruses that we know of, is about 12 to 18. And that has to do with how it's spread. It is through aerosolization of that virus. And then, I think with this, we also have to talk about the variants that are there. So far, we've known about 3 notable variants. The thing to remember about any virus and anything that replicates so quickly is that there is going to be mutations. We have it within our DNA, so does the viruses. As they're replicating, that they're going to have certain mutations. And with that, we had the initial one that we discovered from the UK, and that initial mutation, I think, started in about end of September, October. And now we know that it is found worldwide. I know that recently there was discovery of that in Washington state as well. So it is within our state at this time. What it does is there has been reports that it may cause increased transmissibility. So it's easier to transmit. And what we're learning is because it may bind the spike protein that this mutation causes may bind to the receptors in the lung a little bit stronger than the wild type. But it does not really have, so far, that we know, have found any impact on the severity of the disease. And so far, there's still a question about is it increasing mortality or not? Those have not been answered yet. Nothing that comes out saying that yes, it is, but again, this is still pretty early. And then there's the variant from South Africa, which again independently arose different from the UK one, but it has similar deletion where it does not have disease severity impact. But with that South African variant, the unique thing is some of our treatments that we have used with the monoclonal and polyclonal antibodies, they're not as effective. And then there's the Brazil one that has most recently been discovered. Again, that's thought to just increase transmissibility and then the antigenic profile. Um, Again, we're learning more about this. We don't have all the information about some of these variants. So, but what hasn't changed are the kind of the basic characteristics of the virus, which is, or this infection that it causes. The incubation is still 2 to 14 days after exposure. Most cases do occur within that 4 to 7 day period. However, it is not unheard of that people take 14 days to develop that infection. Some of that it has to do with, how much viral load you may have been exposed to. So smaller viral load may take a little bit longer. But a lot of times, most people do exhibit some type of symptoms within that 4 to 7 days. And then the outliers, these are kind of rare cases that people write about, was 25 days, but it is not a common thing. It's, probably 1 or 2 cases that have been written as case reports. That is not something that's common. We know majority of the cases would occur within the 14 days. And that's where a lot of the guidelines talk about quarantining if you've been exposed for 14 days. And then the spectrum of disease is kind of all over. It can cause completely asymptomatic, or people can have had no symptoms at all, to being mild to critically ill from this infection. And initially, we didn't realize that there were so many asymptomatic cases. But again, as we recently last week celebrated, the 1 year anniversary of the first case in Washington State, we've learned a lot over this past year. And we do know that up to 40% of the cases can be asymptomatic, but that does not mean that you're not infectious. So infection you can still be spreading infection to people who are unsuspecting and at-risk populations. And what we also know is about 50% of the infections or transmission that's occurring within the United States is either from this asymptomatic group or what we call a pre-symptomatic group, which is 48 hours prior to you showing symptoms, you can have high viral loads and can cause you can be causing the infection to unsuspecting folks. So that's why a lot of times, if you've ever heard of contact tracing, how it's done, they always go back to 48 hours from when that exposure was, when that person became symptomatic, and that's the reason why. And what are the symptoms? I think we all know this very clearly at this point, cough, shortness of breath, difficulty breathing, fevers, chills, muscles, body aches, vomiting, diarrhea, and then the loss of taste or smell. That is unique to the coronavirus. It's not the only virus that causes this, but this is one of the hallmark symptoms that have been noted, is that loss of taste or smell. So, I think it's very important to talk a little bit about what the mode of transmission is. I think if we understand what that mode of transmission is, we can stop that spread and do the measures, mitigation measures, all the measures that we need to slow this down and eventually, get a better control on it. So, we have the infected individual. They cough, they sneeze, they talk. Droplets is the more common pathway that this happens, which they create droplets as they're doing that. And as you're close by to that person, and you get exposed to those droplet and you are that susceptible individual, you get that infection. And that is the most common way of getting this infection. Well, we also know that some of these droplets can form droplet nuclei. I think, again, this is more information that initially was like, no, it's only droplet spread, and then there was more information coming, no, there's some aerosolization of this virus. So what that is these droplet nuclei, which are smaller in diameter, which travel, that may travel a little bit farther than the 1 meter, um, but they're present and they can stay in the air a little bit longer. And so that's kind of where that airborne transmission comes from. So, majority of it is that droplet, but then there's definitely the nuclei that can be created, that can stay in the air a little bit longer and lead to this infection. And then the direct contact. So, if someone sneezes on your hand, you touch that on your face, or, as you get that on your hands or anywhere else, you touch it on your face or your mucous membranes, you can be exposed. The one that we don't think, I think initially there was a lot of concern about, but I think that is not the most prevalent way of getting this infection, and it may not be it may just be a small portion or may not be contributing to it, is indirect contact, meaning that someone a while ago left, was infected and it's on the fomites. How long do they live on those fomites? And early on, there was a lot of discussion, is our doorknobs and things like that, do we need to worry about? But that's probably going to be a much smaller portion of how this infection is spread. Mostly respiratory, is whether it's droplets or a little bit of the droplet nuclei with the airborne. That is the majority of the transmission that we're seeing. So, what are the risk factors for severe disease? There has been looking into how much hospitalization of this infection has happened, how much death has happened. So, what the CDC has done is over the last several months, they have looked at and they compared, they made the control group, or that group, be the 18 to 29-year-olds, as that is, in any society, the healthiest of everybody that's there, and compared to see how the younger kids do and then how the older folks do. And with that comparison group, you can see that, kids do better. They have lower rates of hospitalization, they have much lower rates of death. And as each decade goes up, that increases, and that increases pretty exponentially, particularly with the deaths. An 85-plus-year-old is at over 630 times likelihood of dying from this infection than someone who's 18 to 29-year-old. And that's where a lot of the younger folks, particularly the young kids, have the milder disease or asymptomatic. And some of the science behind that is that those ACE2 receptors, where that spike protein binds onto, is much less in the little ones than it is as we get older. So that may be the reason why it's much milder in little kids versus as we get older. And then there's also disparities in race. Looking at that, when you compare to Caucasian, to American Indian, Asian, Black, or Hispanic, every other group has much higher, or a little bit higher, and hospitalization can be much higher in regards to the severity of the disease. So, looking at the socioeconomic status, looking at race and ethnicity is important, because we know that those folks may tend to do a little bit worse if they get the infection versus white or Caucasian or non-Hispanic people. And then in regards to risk factors for severe disease, it all has to do with, again, 18 to 29-year-olds were looked at because they're the healthiest. And then any increase in comorbidities or underlying conditions make you at higher risk. So things like cancer or kidney disease or lung disease, anybody who is immunocompromised, and even obesity, heart disease, sickle cell, diabetes, all of those are things that can put you at increased risk for severe disease. And then there's several groups that we do know of. The most studies is the racial and ethnic minority groups. But out of experience, with what happened in Washington, nursing homes and long-term care facilities are also on that top of that list, because they're the most vulnerable. They're that elderly group of folks. Rural communities are thought to be at risk for severe disease, partly because access to care may not be as good as if you live in an urban setting. Pregnancy and breastfeeding women. Pregnancy can be considered a immunocompromising condition, and so that may put you at increased risk for severity, not just for you, but for the fetus as well. And then anybody with disabilities, and part of it may just be they're not understanding what they need to do, and they may not know having to wear the mask or the significance of that and may not be able to follow. And then also people experiencing homelessness, and that is mostly because of the crowded areas that they may be living in, or the situation that they may be in. So, what can we do to prevent the spread of the COVID-19? We know what the impact is, we know how it's spread, and it's what can we do, particularly as the schools are opening. That's a concern. And I'm a parent. My son is going to in-person school, so I know this is important, and you want to know what is being done. And so, the top 7 things that can be done is, first of all, know how it's spread and avoid being exposed. As far as, if as far as the transmission goes, droplet, airborne, those are most likely the most common ways, but obviously there's other ways of doing that, of having it spread. Practicing good hand hygiene. That is the basic step of any infection prevention, is hand hygiene. We learned of that, over 200 years ago, that we have to keep our hands clean, to take care of ourselves, to take care of anybody else. Also, the physical or social distancing. Again, we know that these droplets can travel a certain ways, and the airborne droplet nuclei can travel a little bit farther. So that physical distancing is pretty important. Wearing a cloth face mask and when out in public or around others, and why that's important, I will share a little bit about that. Again, basic of respiratory hygiene, covering coughs and sneezes, whatever it takes to do that. Cleaning and disinfection of high touch surfaces. Again, we know it's a small portion of indirect way that this infection can be spread, but it is a huge part of making sure that all of the measures are done. And then also just monitoring your health and safety, and making sure that, if you're sick, you stay home. If you've had an exposure, you stay home, because you may be asymptomatic, or you may be pre-symptomatic, you may feel well, but if there's any risk, then you think about that. So, a lot of you may have looked at this most recent. This is, I want to say, just about a week or two old, where the 26th, the CDC had done a study in Wisconsin looking and looking into, what is the risk of spreading COVID-19 in person learning. And they looked at a rural setting, and they implemented kind of the basic strategies that we just talked about: using masks, using small cohorts, using physical distancing, quarantining if anybody had exposure. And during that time frame that they looked at closely, which was 13 weeks, they only had 7 kids who had gotten COVID-19 at school, and no spread, or they were positive, but none of that was felt to be from the school setting. That's not where they picked it up. It was because of the community spread, the high community spread that was going on. And kids actually do a very good job. If they know why, they comply. I think that goes with everybody, is knowing why they need to wear that mask. They are very good about doing that. And I will say, on a personal experience, as we have been working with several schools over the last 6 months, this kind of goes with what we have seen over the last 6 months as well, where if all the mitigation has been to point where everything is being done to the best of the ability, we haven't seen a transmission happen at school. Whatever positive tests that have been coming for kids, it happens. It's in the community. So what kids, staff, it will happen. But because of the mitigation factors, there has not been any spread within that school setting. So, talking about some of these basics, what needs to happen? And again, we walked through every school for Eatonville, and talk through the processes that are there. So these are the basics that they have made sure that is able to be done. There's, hand hygiene, making sure that the hands are clean, which is the most important thing that we can do. Hand washing with soap and water is the most ideal. The key is that 20-second. I think we all can wash our hands, but that 20-second when you actually wash is a very long time. So you have to remember to make sure that you either count to 20, sing happy birthday, whatever you need to do to remember, and make the kids know what that 20 seconds is. Regular soap is just fine. You don't need any antibacterial soap. Ideally would be the primary method, but realistically, we know that can't always happen. So we do have the hand sanitizer or the alcohol-based hand rub. Again, with that, it has to be at least 60% alcohol. And that has been something that has been vetted to make sure that all the hand sanitizers are that throughout the schools. So again, if your hands are visibly dirty, soap and water is the best, but at other times you can use the hand sanitizer. You just keep rubbing it until it's dry. So sometimes, it's always good to know what's a good time to hand wash. And if you need to seek out soap and water, then those are the times is definitely before eating or preparing food that it should be wash your hands. If you've gone to the bathroom caring for pets, or if you're caring for a sick person, your hands are visibly dirty, taking out the trash, kind of the common things that you should definitely be washing out your hands after should be done. But then it is okay to use the hand sanitizer too, again, because it's easily available versus soap and water. And so if you're out in public, you're going to your doctor or sneezing or blowing your nose, if you need to touch your face to take off your mask or do anything else, make sure you can hand sanitize. Or you're out grocery shopping, whatnot, there's hand sanitizer everywhere that is available now. And then the physical distancing, again, close contact. We know that anything within that 6 feet for prolonged period of time. Again, droplets can go about 1 meter, but those droplet nuclei can hang around a little bit more in the air, so that if you're in close contact, you can be at risk of getting the infection. And then also, regardless of where you're at, indoor, outdoor, those droplets can be there. Outdoors better, because it can be dispersed a little bit more, but definitely keeping that 2 arm length for that 6 feet. Not to be in large crowded spaces or large groups. When we walked around, I was very impressed with how the schools had these little caterpillars or little bugs, so that the kids know that too. Yep, there's my bug. I gotta stay on my bug, or I gotta stay on my caterpillar, so that they have those visual cues and they can follow those. And they're very good at following and keeping each other that, hey, you're not on your bug. It's easier to do that peer check when you have that visual cue. Avoid crowded places, limiting the number of people in a room. I think that part of that, doing this hybrid program, is that's the whole idea behind it. Is yes, everybody can get to school, but we got to limit it and do smaller groups so that we can maintain that 6 feet distance. We cannot be crowded in a room, and stay home obviously if you're sick. And then masks. This has been an interesting time for the masks, because initially, when this whole pandemic started, and it's been confusing for people, the initial guidance was, oh, you don't need a mask. And then as we learn more about this infection, we know that masks are an essential part of prevention. And it should not be used as, it should be in conjunction with your physical distancing and not instead of it. The other part, which I think most people have gotten pretty good about having a mask. The part is, it has to cover your mouth and nose. It is not unusual. I'm sure all of you have seen that the mask is below the nose. It is. It needs to be covering the nose and the mouth, and that's when it's the most effective. And it serves a dual purpose. And initially it was like, we're protecting others, because as you are, if you are symptomatic, you're not getting these droplets out. but it is also, protecting you. So it's doing both. It's protecting you from that droplets coming out so that someone else, if you are asymptomatic or pre-symptomatic, isn't getting exposed, but it's also protecting you in case there are these droplets, and that can protect you. And that's partly the reason why the CDC has been pretty firm about no exhalation valves or vents with these masks, because it's really not protecting anybody when that's the case, because that those droplets can come out, and the studies have actually shown that with those valves, actually you create more nuclei because it comes through that filter, and may have more of that nuclei, so it can stay in the air a little bit longer. And then the other thing is to avoid using bandanas. And part of that is because a lot of times there's no closure at the bottom, so things can still flow down. So with the bandanas, the neck gaiters, initially when some of the neck gaiters were studied, they were the single layer, and they, again, similar, where it wasn't a fibrous material, and droplet nuclei could come out of it. So they said it should be at least 2 layers. More is better. But and also I think the other thing is some of those slide down. So you have to see, is it maybe 2 layers, but if it's sliding down, and someone's having to put it back up, or it's under the nose, it's not doing what it needs to. So that you just need to be mindful for that. Again, not a substitute for social distancing. And then obviously, little kids under 2 may not know the purpose of that, may not be able to take it off when they're a little bit short of breath. If someone who doesn't understand that purpose, even if they're not younger, should not be wearing it. So if they're incapacitated, or are not able to remove that mask without assistance, they should not be wearing it. So, why did we go from saying that no mask to wearing masks? Some of that is looking with the studies in regards to the efficacy of it. So, this study looked at how the infection can be spread. So, this is looking at patients who have had positive nasal swab and throat swab for the coronavirus. They look to see what happens when someone does not have a mask, and where are the droplets going. So without a mask, the droplets are going, that you could see that within the air. And then if someone is wearing a mask, you really don't see any droplets. There's no viral copies that are noted there. And same thing with the aerosolization. We talk about the droplet nuclei. Things without a mask, there's those droplet nuclei that are going and spreading. But if someone has a mask on, that stays contained. So this is where the benefit of the masks is. So, and then what should we do and not do with the masks? With the mask, we have to wear it properly. It should not be hanging on the side. It should not be, again, hanging below the nose. It should be tied appropriately. Shouldn't be touching it, head, elbow, wherever. I've seen it all other places. So those are the places that it shouldn't be. It should be on the face. If you have the loops, that's what it should be. If it has the ties, both of the ties should be done. And when removing a mask, make sure you clean your hands, and try and take it out from the side in case you were exposed to somebody that didn't have a mask on, or if there was droplet nuclei that may land on in front of the mask that you can that have the infection. Tips for, sorry, that's my daughter in the background. Tips for reducing risk of getting COVID-19. Again, the hot spots, what that increased risk is, there's no mask, it's indoor space, a crowded space. All of those put you at higher risk. Things that decrease your risk. Masks are worn, again, outdoor spaces better because you have better ventilation. There is, again, keeping that social distancing. So all of that will help decrease that risk. So the other part is covering cough and sneezes. We know this is respiratory hygiene. Even before COVID, this has been one of the foundations of infection prevention, is always cover your mouth and nose with a tissue when you're coughing or sneezing. Throw away the tissue if it's in the trash. And then immediately Wash your hands with soap and water for at least 20 seconds, or use the hand sanitizer if that is not available. And then cleaning and disinfection. Cleaning and disinfection on a consistent and regular basis can definitely help. We've reviewed the plans that are in place for the schools, and there is very good plans on getting the high touch surfaces to be cleaned on a regular basis. So those are the recommendation is some of the high touch surfaces get cleaned on a regular basis, frequently throughout the day, and that is in place. Obviously, if the area is dirty, you have to clean it first and then use a disinfectant. And sometimes it gets confusing. What is cleaning? What is sanitizing? What is disinfection? So, cleaning is using soap and water on something that's visibly dirty and wiping that. It does not kill the germs, it just cleans the area. And then sanitizing, you're using it to decrease the amount of germs or lower the number of germs that to a safe level. So, a lot of times that's used in the food service. And again, you do it while until it's visibly clean. Disinfection is actually using a product to kill those germs. And the unique part is each product has their own time that it takes, and what we call that as a wet time. And so each different product has to be, or that area that you're trying to disinfect has to be wet. And again, it depends on the product that you're using. Some are 3 minutes, some are 10 minutes, and easier to achieve that 3 minute, a little bit harder to achieve that 10 minute. But they can be good products that are doing that. You just have to be very mindful of what that wet time is, because if it's not wet for that entire time, you may not be getting that full disinfection. So again, monitoring your health, be alert for symptoms, especially as the schools are opening. So, cough, fever, chills, difficulty breathing. So all of the symptoms of COVID-19, if any of that happens or anybody around you has that, then you may have been exposed. The other part is getting that testing done if there is that concern. I know that there have been spots with the school district that you can get tested. So you can get that testing if you are symptomatic. And then taking daily temperatures is important. Um, a lot of times exercising or taking medications like Tylenol can reduce that temperature. So just make sure that that you're not exercising right before you take that temperature. I know as kids are coming back to school, it's cold, and if they had to stand outside before coming in, that it's okay to wait, you do the screen, wait to make sure that the kids have had chance to normalize. They may have their hats on, which make their foreheads a little bit warmer, or it may be too cold. So just let them normalize that temperature, and then that can be checked to make sure that there's no fever, as the schools are doing that screening. And then to stop the spread, all of these measures have to happen. It's not just let me pick one or two. It has to be all. If you do all, that's the best way that we can prevent this infection from spiraling into exponential numbers. Staying the physical distancing, covering your cough and sneeze, wearing a mask, not touching your mask if or eyes, nose, and mouth, cleaning and disinfection, staying home when you're sick, and washing hands or hand sanitizing if that's not available. And why I say it's not just one all that needs to happen, it's that Swiss cheese effect. We have multiple layers that improve success, because the likelihood that one measure will fail is pretty high. If you're just relying on one thing, there's a high likelihood that that measure may fail. But that's why you have all of these different measures. So you're doing the physical distancing, we're doing the mask, the hand hygiene, the avoiding of the face, ventilation. That's the other part. You have a good asset with John, who has looked at all these ventilation and air filtration within all the schools and tried to optimize that, so that plays a big role of that. Fast and sensitive testing. So I think you guys are lucky that you are able to have that testing in the schools, because not all the schools have that capability. So That all of those, every single one of those is helpful. And lastly, we have the vaccines, which are again the gift of science that we've had, that we have the vaccines that are available, that are effective. 94 to 95% efficacy is very good. All of the other vaccines that we have had recently don't achieve that, but having that is quite a feat. And then quarantining and isolation again, as we have to do that with the contact tracing if you have been exposed. So there's the personal responsibilities that all of us have to do, kind of the individual steps, that, and then the shared responsibilities. And I say shared because I think that's kind of where your schools and your school districts have come in, because they have done all of those. They have protocols in place in regards to what can be done. And then lastly, the vaccines are coming into play. I wanted to just touch a little bit about the vaccines. Currently we have the two on the market, which is the Pfizer vaccine and Moderna vaccine. Both of those are messenger RNA vaccines. They're both 2 doses, so you need that booster dose to get that full efficacy. Again, the 94 to 95% efficacy. And we know that of over 40,000 people were in each of these studies. And there really were not any severe cases in patients who had these vaccines. So they're very effective. I think there has been a lot of concerns about, the messenger RNA. This is not new technology. This is something that has been used in the past. And so I wanted to just give this may be a little bit too science oriented, but I wanted to show this. And then I heard a metaphor that I actually really enjoyed from my partner, that I'm going to share with you. So, what are these vaccines? So the nucleus has our DNA. This is just kind of some of our apparatus that we're creating our own proteins. This messenger RNA vaccine is in this lipid coat, and that's why it has to be so cold. That because that lipid coat will degrade if it's not in that cold environment. So and it's stable for about 6 hours. So that's kind of why they say that once it's been thawed, the vaccine has to be used within that 6 hours. So it goes into the cell. The messenger RNA uses the ribosome, which is the machine or our cells that make protein. So this will make the protein and then pump it out. And our body will recognize this as, this is not our normal protein, this is foreign protein, and then bring it back in and start the process of having an immune response. And so this way you get that immune response, you get that antibody mediated immunity. This is the metaphor that someone said is, what it is this is a recipe, and it's someone is coming in using their recipe and using your utensils, and they have the recipe right here. They're just using your utensils to create whatever they need to make, which is that spike protein, and then your body eats it up and makes that antibody immunity, mediated immunity, so that you have it. And if you see the virus naturally, then you will be able to fight it. And this is again efficacy, how efficacious it is. Looking at that's kind of, this is where we're seeing that 94 to 95%. You're seeing that this is the number of cases in people who got the placebo. The blue line is that, and then the red line is people who got the vaccine, and the incidence of getting that infection, which was pretty minimal. And so where are we at with the vaccine rollout? I will say that this has changed. This is probably the 3rd rendition of this that I have seen in the last month or so. So this has changed. So, the tier 1 was the high risk healthcare workers, long-term care facility residents, and first responders. So, I think that now with Washington, we have moved to our 1B tier, which is anybody who's over 65 or 50 years old and living in multi-generational households. Pretty soon, they're going to be moving towards the 1B. Again, timing of that all depends on how well we do with that 1B group. And that includes our teachers, educators, staff, everybody in school care, childcare that is doing in other kind of congregate settings. And again, you can see the other tiers that are available. So eventually, this pandemic will end. The vaccines are bringing a kind of a peak of a light at the end of this long tunnel. Like I said, we recently celebrated the 1 year anniversary of the first case in Washington in the United States. The precaution measures will need to remain in place even after vaccination. And the reason is that, in order to prevent this vaccine, this infection in a community, we need to have herd immunity, whether it's from natural infection or with vaccination. And that will take time. And what that percentage is, the higher the better. But at least 50% to 80% is kind of the guesstimate that has been provided, is that 50 to 80% of people either would have had to get vaccinated or been immune from it, from this infection, to say that we have herd immunity, and we're not there yet. Here's just some of the references that I used as far as information that is available. And I think we are now going to be at the Q&A session portion.
Well, thank you so much, Doctor, for that presentation. Heidi, you want to start with our first question?
Sure. So the first question that came in was, how does the average class size compare to the class sizes and interventions that are cited as evidence that the return to school can be done safely? I understand that they will be spaced 6 feet apart, but the numbers of students in a class also matter.
That is correct. And I will say that that actually, I think, has the maximum number has been decided by Department of Health, and that's 15. So, ideally, you have to look at what the room size is and space out the desks or where the kids will be sitting. So the maximum number is going to be 15, but it may be less. It may depend on what the class size is. And I think and I will say, that's the background work that's happened over the last several months that the teams at the different schools have been doing. They're looking to see how can we place these desks 6 feet apart. So it may not be all 15 kids are in that room. It may be a smaller number, but the maximum, that part is 15.
Thank you.
In other cities and districts where adolescent students were able to return to school safely, how many classes per day did they attend? And how large were those classes?
I can speak for the schools that we have gone towards, and a lot of them, again, it varies because it depends on the size of the room. A lot of times what we did see is that teachers had little markers, especially for the little ones, because again, visual is the best way for the little ones. So they had little stickers on the ground where the desks would be, and they mapped it out. So how many kids, it all depends on the classroom size. And again, as long as that physical distancing can happen, then that is what they were trying to do. As far as how many classes they were in, usually most schools in the elementary, the kids stay in the classroom. They don't go. I know that in middle school, some they go from room to room, and we say try to minimize that as much as possible, but understanding that sometimes you may be traveling to go to a class several times a day, and so there's pathways that have made it to be safe. So one directional way of going to the class. So there's no congregation in the hallway. So walking towards in all the schools, no one is using lockers. So that's one way of preventing that congregation in an area. So it's, like I said, one-way traffic, everybody keeps moving, they're passing by. exposure wise, everybody should be wearing a mask. The mask should not be coming off. You're not standing and talking. So all of that needs to stay not just within the classroom, but as you come out of the classroom, as you're in the hallways, as you're going from one class to the other, the kids need to continue kind of recognizing and doing the mitigation efforts.
If masks are essential for preventing the spread of illness, is it wise to allow students to eat and drink in class, and would eating outside be a safer option?
So, we have always recommended that if you, as you're eating, to open the windows, doors. I know that it can be a health hazard for an all day thing, but during those times, it's reasonable to do that. And again, they would still have to maintain that 6 feet. So increasing that ventilation during that time frame is again, by opening windows, doors, is helping do that ventilation. And the other part is, the ventilation that's in all of the rooms was created for, probably 20 plus kids. Now that number is much lower than that. So that ventilation is already improved in that you have decreased the number of people that are already in there. So that's helping. Could this be better outside? If it was possible, would be, but I think with living in Washington and trying to get just the logistics, probably I think it's not something that is easy to do. It's raining all the time, at least in the winter time. It's beautiful in the summer, but it would be hard to do that. But I think if the option is there, that if the weather is nice, kids want to go outside and still be socially distanced and do that, and you're able to do that, that's a reasonable thing to do.
Thank you. The next question we have is about exposure. What do you define as an exposure? And if there is a positive case in the class, will I be informed?
So these are pretty well defined by as far as what is an exposure, and you have to involve the local health jurisdiction because they are the ones that help guide all the schools. And I know everybody on your team has a very good relationship with the Pierce County Health Department. And again, they will help guide as far as that contact tracing, as far as who is the one that's exposure and all of that. So they will work closely with the schools in determining that.
Thank you. The next question is, have any changes been made to the ventilation system of the school to help prevent the spread? And you might be able to weigh in on this one a little bit as well.
Yeah, absolutely. Yeah, so in a lot of our buildings, we're very fortunate to have high efficiency filtration and ventilation, and we have a lot of control over that. So we're able to increase the amount of air that comes from outside and put into our classrooms. And we're also able to upgrade our filtration system to be able to slow that spread of the virus through the air. And then in spaces where ventilation is difficult, or where rooms have low ventilation, or it's tight quarters, we also purchased air purifiers that are HEPA filter rated for our staff and our students. The next question we have, there are new strains of coronavirus emerging around the world, and some have been found in our own community. Are these strains more contagious, and does this increase the risk for students being in person?
So I think, as I'd mentioned earlier, we're still learning more about these strains, but what we do know for, the UK strain, yes, it has increased transmissibility. But having said that, we have to look at our mitigation measures, wearing a mask, making sure that you're socially distanced. That does not change. The virus has to be in the environment. I mean, it has to come to me. I have to be exposed to it for me to be able to get it. And if I'm wearing a mask, if my ventilation where I'm at is good, if I'm keeping my social or physical distancing, if I'm in a room where the ventilation is good, and I'm doing all of those measures, the risk is probably going to be no different than any other coronavirus. So I think what's important is, I think sometimes people have gotten lucky if they don't wear their mask properly or it's down, and we can't base it on luck anymore in that regards, that the wild type may not have been as good at transmitting, but the some of the newer strains are. And so we can't have that lapse in our measures. You can't let that mask slide. You can't forego hand hygiene. You can't do all of that. I think it just is more imperative that all of these measures are done, and they are done right every time.
Thank you. The next question is, should schools wait to bring all their kids back to in-person learning until all kids and staff members are vaccinated?
The previous studies, none, we haven't had the vaccine until the last couple months. All of the studies where they have brought kids back in. So Wisconsin was just kind of where the CDC has done, but there's more data from the European CDC as well. And they have looked at different countries. I mean, they've looked at Sweden, they've looked at France, and the key is doing these measures, doing the mitigation measures of again, I feel like I'm that broken record that keeps saying mask, hand hygiene, social distancing, but those are the things that work. And even, they continued that. I think a lot of you may have heard that Sweden really didn't shut down as the rest of the world did. That is kind of their experiment, but they did do all of the measures, and there was no in-school spread that they had noted. And again, a lot of the other European countries had open schools. We haven't had that similar, studies done in the United States since everybody shut down. But we can extrapolate that, if those measures are done, yes, vaccination is great. Again, it's kind of that Swiss cheese, it's that layer that we need. But it's not save all with that either. We need to continue to do all of those layers.
Thank you. Is there a concern that Chromebooks and class materials going to and from school could bring the virus into the home?
It is my understanding that each child, each student will have their own, and there's no sharing between students. So I think that to decrease that risk, that's what it is. It's your own thing. It's your own stuff. You're not sharing it between each other. The other part is that cleaning and disinfection is going to be happening. We had talked about as if kids are sharing even tables, then they should be cleaning any equipment that they're sharing. It should have that cleaning and disinfection, and you have the kind of the cream of the crop product in your school facilities. And I think even in the healthcare setting, we're jealous of what is available, which is the Oxivir, which is one of the best. It's a hydrogen peroxide based disinfectant and cleaner, and very safe. Kids can use it, and I think it's been approved for kiddos on 6th grade and over to be able to use it. It has 000 as far as the safety profile goes, so very safe for the kids. It breaks down to water and oxygen to use. So that's the key, is if anything that's being shared, yes, it needs to get disinfected. Otherwise, they're just bringing their own thing and making sure that they're doing the hand hygiene. And if they have clean hands, they're using their own stuff, kind of similar to what they'd be doing at home.
Thank you. One of the last questions we have is, the NFL had football without masks. Why can't students play sports without a mask? The oxygen requirements increase with exertion, and we don't want a player dizzy because of increased CO2 in their bloodstream.
I think we just don't have all the provisions that the NFL did. NFL was testing almost on a daily basis. That part, again, the symptom management that's going on, everybody's doing that. But even with that more frequent testing, many a times games were postponed or canceled because there was one person who did test positive, and there was concern that that would be spread because they were not wearing masks. So I think that, and there was transmission. We know that several teammates in several of the football teams did get it. Wasn't just to one person, it spread within a team. That's the reason why the kids, need to wear a mask. And there's levels of high activity, moderate activity, where it is recommended that you do moderate to low impact sports for that reason, because I completely understand, yes, it can be an issue, and that high impact sports are not done, or you try and stay away from those and try to do the guidelines that the WIAA has released.
Well, thank you so much, Dr. Condell. We're run out of time for tonight, but we want to make sure that if you have other questions, to go ahead and reach out to your building principals, and they would love to go ahead and talk to you about logistics, and any other safety concerns that they have. And again, I just want to thank Dr. and your team of professionals who were out on our campuses, took the time to come out and really just give us some great feedback and information and education around the safety of our buildings.
Thank you for having me. Great questions.
And I would just like to close out and say thank you for joining us. The IPAC consultants, thank you so much for your partnership, walking us through. I want to thank publicly John and Heidi, our local experts, and families. I just want to reiterate, we had a great vaccination event on Saturday, and I know that many of you saw that on the news. It was wonderful to be able to provide that for the community. And we will continue to have COVID testing on site. And we have requested to be part of the Gates and the state Return to Learn pilot. So we feel like we are ready and that we have all of the Swiss cheese items for being as safe as possible. We thank you for your trust in sending your students here, and have a great night. Thank you.
Thank you.